Prostate cancer is becoming very much a team sport in that we're recognizing early on now that there are roles to play with both primary care, with supportive care, and with both medical oncologists, radiation oncologists, and urologists. The natural history of prostate cancer can range from a few years to more than 20. The care of these patients crosses all of those disciplines. We are frequently working together as a team in our multidisciplinary clinic for newly diagnosed prostate cancer patients to make sure they get a fair and balanced and as objective as possible description of the treatment options so that we're not sending everybody to surgery or everyone to radiation oncology, because not every approach is appropriate for every patient. There's risks and benefits associated with each of these therapies. Same is true later on in the natural history of this disease. As patients progress into the metastatic and castration-resistant setting, it's really important that they see a medical oncologist, but at the same time, that patient's rapport and trust is predicated largely on the long-term relationship with their radiation oncologist or the urologist. We can't simply cut the cord from that. It's really important for these patients to buy into concepts like chemotherapy or radium-223 or Sipuleucel-T or even these hormonal therapies, that they have the trust and support from the physicians they know, as well as some of the newer physicians becoming involved in their care. So to me, multidisciplinary care is really critical. And I think probably the last piece of that is palliative care, and involving many of our palliative care team folks to help make sure we keep these patients in as good a functional status as possible while we go through a series of treatments. So the care for prostate cancer patients has gotten enriched with all these therapies, but it's really required even more so than ever a collaboration of physicians in order to optimize outcomes.
Multidisciplinary care, I think, is at the real heart of cancer care today. The Duke Cancer Institute changed the way that they delivered cancer care a number of years ago, where we put the patient at the center and had everyone really rotate around that patient. We took a single cancer center approach where we had disease-focused groups that came together and talked about patients. And I think that's really the best way to deliver cancer care. I think when you take a diagnosis like prostate cancer, one thing you really want to make sure you do is put all the key decision makers in that room with the most key decision maker, which is the patient. And when you have the prostate radiologist, you have the oncologist, the medical oncologist, the radiation oncologist, the urologist, everyone involved, you can make much more informed decisions and you can provide a lot more options to that patient. So I think multidisciplinary care is really where cancer care is and should be in the future. Multidisciplinary collaboration really comes down to communication. We have a great group of docs that we work with at the Duke Cancer Institute that really trust one another and really value one another's opinion. And I think that's really at the key of administering really high quality cancer care to our patients. So we have tumor boards where we discuss both straightforward as well as more difficult cases. We have RAD path correlation conferences where we go through, is what we are seeing on the radiology concordant with what the pathology is seeing, so that can then more appropriately inform decision making on the part of surgical treatment or oncologic treatment. So I think communication really is the thread that runs through any successful multidisciplinary team for cancer care.
So the multimodality approach is very important because we have to identify when this patient is at the point in their disease where they should receive radium-223 as opposed to the therapies that they've already received. I think that all patients with prostate cancer should be evaluated by a urologist, a urologic oncologist, and a radiation oncologist. After a full discussion of all the available modalities, these clinicians should be the ones to decide what order to do the therapeutic layering.